to join you and to be invited in this meeting. So apologies for the technical problems. So if I may have the first slide, please, I would appreciate. Okay, the talk essentially will address how are the technical solutions to support integrated care services in Catalonia. But before we go into the focus of the talk, that will be how these are evolving, I would like next slide to explain a bit the structure of my talk. First, I will introduce a bit how is the Catalan health system, how we understand the digital tools supporting integrated care services and how these are evolved, what are the tools that are really mature and fully deployed in our region. And the third part of the talk will show somehow the limitations of the current setting and how it's evolving towards the future. Finally, I would like to share with you the policy that has been developed in the last decade in terms of risk prediction. What are the tools that are really available right now and how they are evolving, how we are working to deploy and to expand them towards the needs, to cover the needs that we think we are having already. All this is being done as partially of the JADE Care, the Joint Action for Implementation of Digitally Supported Integrated Care Services. So let's go ahead with the presentation. Next slide. The next two slides will explain a bit the general characteristics of our region, which is in the northeast area of Spain, has 7.7 million of inhabitants, has a gross product that is a little bit above the average in the European Union. We have a rather elderly population. People above 65 years is 19% and is growing quickly. Our birth rate is quite low. Our survival rate is quite high, and people in general is quite satisfied from the healthcare system. The health system has these characteristics, has a universal coverage, a public financing of the services. We have one key point that explains a bit the evolution of the system, which is that we have just one single public payer. As I will explain, we have quite a good interactions between the civil society and the government. So there is a lot of top-down and bottom-up interactions. Equity is a main goal of the whole approach, and continuity of care and integration across the system and with social support is also a goal that is highly promoted by our authorities, by our parliament and by our government. Just to let you know that healthcare is fully governed by the region. So there is at central level in Spain, there is coordination, but healthcare is fully transferred to the region. So next slide. So here you have few characteristics that some of them I already mentioned. The total budget per year is 20,000 million euros. A very important issue is that despite we are talking about a public system, the system of providers is very, very heterogeneous. We have around 160 entities, and these entities are less than 50% are owned by the public system. The other entities are either private or non-profit, private for-profit or private non-profit providers that have contracts with the government. We have also a very important heterogeneity in terms of ICT support, the electronic medical records are quite different among the different hospitals. And we are covering from social support to healthcare, intermediate care, hospital care, and primary care. So the challenge is quite important, and I will explain how has been evolving over the last years, what we learned during these years, and how we are planning the future. Next slide. Here you have quite a comprehensive evolution of what has been the technological support of the services. You have at the end of the 90s, primary care, the primary care electronic medical record was already established, and the hospitals and intermediate care began to have electronic medical records. In early 2000, the index of patients, what we call the RCA, was established, and that's key to establish interactions between the different databases. Electronic prescriptions were established by mid-2000, now cover 100% of the prescriptions. The electronic shared electronic health record was established at second half of 2000, and this is, in reality, is not a health record. In reality, is a platform of health information exchange. This is the area where we have learned a lot, and it's the basis of somehow the evolution of the whole system. Then by mid to last decade, we began a process of implementing process management into the system in a very, let's say, very simplistic way. And also, since a few years ago, there is a full deployment of sharing imaging in the system. This altogether was going on together with a myriad of pilots in terms of monitoring, things like this, in different providers. And but here I am showing what is deployed in terms of mainstream services providing digital support at regional level. All these are mature tools that has been working for a while in our system. Next slide. Such that we have a good interaction, a good exchange of information between the homes, primary care, hospital, intermediate care, pharmacies, etc., analytics. We have a good system of to dealing with the semantics of the system, with more and more with what we call management of care pathways. And this is somehow a sort of high-level description of where we are now, which I think provides good connectivity, overcomes problems of fragmentation, and a very important role here is the personal health folder, the personal health portal, where the patients are doing a lot of e-consultations and interactions between the patients and professionals, and also administrative services virtually. All this has experienced a very huge evolution in the last 2 years during the COVID pandemics. Next slide. But all this development and the technological developments, I believe that I need to somehow explain how has been done and what is the dynamics behind and what are the principles. And a very important issue is the role of the health plans. The health plans in Catalonia usually have 5 years duration. The last 2 health plans from 2011 to 2015 and from 2016 to 2020 have been very important in terms of both integration of care and digitalization. And the combination of the existence of these health plans with the fact that there is only one single payer that established contracts with the different providers has been the driving force to promote the change. In addition, the way that are organized the health plans, with quite a good participation of the society, and in particular the professionals, ensure and promotes the top-down and the bottom-up interactions. This is a key issue to explain how is evolving and how will evolve the future the system. And in late 2019, we celebrated somehow the 30-year Catalan health planning. We got the supervision of WHO, and the current plan that's being elaborated for the next 5 years is done jointly with WHO. So that's a very important, let's say, characteristic of our system that explains the evolution. Next slide. But besides the plans and the actions at regional level, there are a lot of different pilot experiences or initiatives that are being promoted more at local level or at provider level. And here I would like to mention and describe briefly an initiative that takes place in our hospital clinic in Barcelona, that plays together the hospital, the university, and the EDVAPS as a research foundation. Here you have a photograph of the whole institution, and on the left side of the slide, you have a map of Barcelona. Here you have the sea on the bottom, and 4 different districts. Our district, Barcelona Esquerra, is the one in green and covers around 500,000 people, has 4 hospitals and 19 primary care centers. And in this area has been, during the last few years, a very strong experience of functional integration and digitalization, raising the concept of what we call territorial care, and linking the hospitals with the primary care, such that the specialists in the hospitals, actually, we visit also primary care level, we advise the primary care doctors, and we establish common protocols that allows to address policies on chronic patients in a very effective way. Next slide. Here I would like to share you just few examples of how we have evolved. We began early 2000 with some big European project. The ISBE, the Barcelona Esquerra Integrated Care, was created in 2006, at the same time that one of the big services that was home hospitalization and early discharge was deployed as a mainstream services. And between the period 2009-2019, this decade, the whole area was getting very, very mature, with a lot of interactions with the regional government, and the area was serving as a pilot area of integrated care programs. And that's where we generated what we call the Catalan Open Innovation Hub, that was selected as an original good practice in Jadecare. And during the period, and we have established somehow the parameters to do large-scale deployment of integrated care, and the parameters for digitalization that I will share with you in just a minute. So just summarizing a bit the lessons learned during this period. And here in the right part of the slide, you have some of the key services that are quite representative, although are not unique. One is remote support to high quality diagnosis in primary care, wellness and rehabilitation, home hospitalization and early discharge, and prevention of hospitalizations. Next slide. During this period, we have spent a lot of energy in the area of the methodology to generate evidence, going from the evidence on efficacy generated through randomized controlled trials to evidence on effectiveness at real-world settings using implementation research tools. And this led us to get experience. Here I am showing how the publications linked to home hospitalization have been evolving to not just taking into account controlled scenarios, but real-world scenarios using methodological tools appropriate to assess not only effectiveness, but long-term quality assurance of the services after adoption. That is a very central part of our activities. Next slide. And also this has generated sort of, let's say, framework for evaluation that is displayed in the slide. I don't have time to go into details, but is based essentially in the concept of quadruple aim. So taking a lot into account professionals and patients, and taking into account that the digital tools are supporting the services, but the principle are somehow the principles that here you have the publication where we describe this kind of framework are based on evidence of efficacy and effectiveness, clinical leadership, taking care of engagement of patients and professionals, effectiveness proven in real-world scenarios, using robust and selecting robust and user-friendly technology, and having as a main principle value generation at healthcare level. I don't have time to go into details, but basically most of the developments that we are doing now are mostly fully aligned with what I will be explaining at regional level, but also we are testing the concept of what we call adaptive case management. So using technological tools that combine monitoring with communication channels that allow the professionals to face non-standardized and not expected situations, and somehow provide tools to the professionals that such that they are independent from the support of the technological support. This is being tested successfully right now in one specific program that's called pre-habilitation. That's part of the program on healthy lifestyles to prepare high-risk patients for surgery. And we believe that's the way to go to increase engagement of patients and professionals and to overcome some of the common resistance that we see with the introduction of digital tools to support integrated care. Next slide. Also, a very important part that I will address at the end of my talk is the strategies for risk assessment. And here what we work is in the combination of what we call population-based risk assessment using the adjusted morbidity groups. I will explain in more detail at the end of my talk. Clinical data, informal care data provided by patients, so self-tracking data, and data from biological research. And we conceive this as tools feeding the clinical decision support tools and helping us to do service selection. We will not have time to go into details. I hope that the cooperation in the area of risk prediction with Estonia will help to, let's say, interact and learn from each other on how we can progress in this area. So, in summary, the use of the service as the center and as a proper assessment of digitally supported services and the focus on risk prediction are two characteristics of the approach that we are doing. Next slide, please. So, but here you have a list. I will not go into detail of some of the current problems that we learn about the use of digital support, the current digital support on health information systems. Basically, the heterogeneity, still the fragmentation despite the health information exchange, somehow they are not prepared to support collaborative work among professionals. They are rigid, they are high cost. The level of satisfaction among professionals and managers is not good. So all this somehow led in the last 4 or 5 years to think about how to change the whole policy on digital support in Catalonia, despite having the basic tools to support the system. Next slide. And basically, the choice was to go to what we would call a knowledge-driven platform. And we exclude, when I say we, I mean the Catalan government, exclude the idea of purchasing any commercial offer, also purchasing part of the offers, linking them, or update the existing technology. And our government decided to go for a novel approach that has been designed in the last 3-4 years and is currently being implemented since second half of 2020. And I will just explain at very high level because I don't have the skills because I am basically a clinician, but I think will help you to understand what are the directions that we are going. Next slide. So basically, this is the summary of what we call the strategic plan for the new information health system at regional level that will guide the contracts between the central government, the regional government, and the providers. And this, there is a small version in English that is accessible through the web. And basically, what we are promoting is a clinical information model. Next slide. That will cover bit a bit with all these phases. I will not go into details, but better management, simulations, help to diagnosis, predictions, and at the end of the day, introduce artificial intelligence to support decisions from the more we go up to the tip of the arrow, more sophistication, more maturity required, and more competitive advantage. And the 5-year program that is underway, it's trying to cover this. And I will explain just superficially what are the, let's say, the underlying principles supporting this change. That it's based on taking advantage of the use of intelligent use of the data generated by the system, which means at the end of the day, to bring the system into the cloud and generate a transformation in different providers such that we have data lakes that allow this kind of approach. Next slide. And here you have a basic description of the concepts behind the knowledge-driven platform that is being built up in our area. I will explain you in a minute the tools that we are using, but basically the simplistic idea to understand the whole change is that we separate the concept of the care pathways, the structure of the services from the technological part, from the software, such that this allows somehow more maturity to the professionals and more flexibility and more responsibility in the management of the services and more independence from the technological aspects. And all this is being done, next slide, using what we call the standards, the open EHR. The open EHR, here you have the main characteristics, can be built up on existing tools using the Agile 7, Fire, etc. Is an open source system, and the basic characteristics is the one that I said, which is essentially to separate the data management from the processes, the logic of the processes. We are developing this in conjunction with and big interactions with other countries in Europe that are moving in this direction, especially countries like Finland. And so far we are in an initial phase, and we are building up the primary care electronic medical record for the whole region. that will be shared by all the providers at regional level. Next slide. And here, just to, I don't have time and I don't have the knowledge to go into details, but essentially this is the type of approach that you can see in the slide. There is a conceptual split between the platform of services and the implementation technologies. And obviously, this generates a lot of somehow risk, but also opportunities that will be analyzed in the next slides, please. Next. So we feel that will improve health outcomes with more satisfaction, mainly from the professionals, will increase clinical productivity and consistency of the data and the processes, and will allow sharing processes across levels of care, will be reduction in cost and in time, essentially because we have to deal with and combine a lot of different providers, and also we increase modularity and independence. Next slide. We are aware of the risk, basically the need of transformation of the manpower, the risk of timely development, migration, etc. But I can tell you that the first phases of the change are being well handled, and in general, people are satisfied of the roadmap and the progresses about the main milestones in all this change. Next slide. Finally, I would like to just spend very few minutes into another area that we believe is very characteristic of our system, and is the use of the adjusted morbidity groups for population health risk assessment, which is somehow one of the complementary tools to do initially what we call case finding or screening to do preventive policies. But at the end of the day, I will try to show you very briefly how we are progressing from this concept that was running from 2013, was expanded to the whole of Spain, around 40 million people. And now we are trying to exchange with other areas of Europe. How we go from this system to personalized medicine. And basically, let me just spend 1 minute explaining the concept behind adjusted morbidity groups. The adjusted morbidity groups are based on the concept that we have all the historical and the current medical problems of the patients, the diagnosis available, and we can differentiate between acute and chronic diagnosis. So the tool, the GMA, is based on the number of diagnoses and the complexity of the complexity of the multimorbidity and the impact of this multimorbidity into the healthcare system. All our citizens are updated in terms of GMA scoring every half a year, and such that we have the risk pyramid of the whole population. So far, we are using the risk pyramid essentially for at health policy level to define investments, to define case finding strategies, and to define screening. But next slide. Here you have the workstation in primary care, and you can see that you have on the right side the diagnosis of the patient, and on yellow the characteristics of the GMA for this given patient. So myself as a doctor, when I do the interview with the patient, I can see the whole context of the patient in terms of GMA scoring and what are the main problems that explain this GMA scoring. This allows me somehow to contextualize very well the clinical situation of the patient. The idea is that in addition to this GMA scoring will be part of, will be a covariate in complex models doing predictions based on multi-source data. Next slide. And such that we increase we do a better risk prediction. And here is where the COVID has done a very spectacular, has helped to do a very spectacular progress in terms of moving from use of GMA for health policy purposes to use of GMA in the clinical arena. And basically has been very useful to estimate the risk of mortality and the risk of hospitalization and somehow establishing policies for management of the pandemics. Next slide. And also accelerating the way that we are managing the data. And basically the two concepts, and that's the message of this slide, of population risk assessment and patient-based risk assessment, we should look at them as complementary approaches. And next slide, what we want to is to make a real progress of what we do, what we call multi-source clinical predictive modeling, where we use informal care data, environmental data, social data, etc., with clinical data either reported in the electronic medical records or patient self-tracking, with data coming from research, such that we can, in the future, and also the disease trajectories of a given patient, such that in the future we can generate tools and validate tools for better management of the patients with support of the knowledge accumulated in the digital data. Next slide. And the hypothesis that we have been working at hospital clinic level, we hope that we'll be able to transfer at regional level. Next slide, for service selection. What has been somehow the keys for this kind of change? Here you have in the slide the political consensus, the long tradition in the Catalan health plan, somehow a lot of networking and a lot of entrepreneurship. We have been facing some resistance, but if we base the change on clinical champions, we think that this is quite effective. And we analyze and we take the COVID crisis as an opportunity for the change. In fact, has been an accelerator of all this change. Next. And I think that is just the last slide where I would like to acknowledge basically the collaboration between what we call the DS3, which is the group of our government that promotes digitalization of the system. INCASIM, that is our group that looks for the convergence between integrated care and system medicines at the hospital, and the whole network of institutions that conform what we call the Catalan Open Hub Innovation. So thanks a lot for your attention, and I hope we'll have some time for a few questions. Thanks. Yes, yes. Go ahead. Yes, the very general standards. We have TIC Salud, which is the agency taking, we have two main agencies that collaborate with the ICT strategic area, run by one director that's called Jordi Piera. And this one is TIC Salud, the other one is Aquas, that deals with quality of care. And the standards are HL7 Fire, SNOMED, the standard ones. Well, traditionally, the Basque Country and Catalan have been somehow drivers of the change in Spain. Now we have other mature areas like Andalusia, Valencia, etc., South, East, etc. And one of the big criticisms, and the central government was just playing a role of coordination, but this role was quite weak. Lately, basically because of the COVID and also because of the inputs of agencies like the European Commission or the WHO, the government is putting more strength, the central government, on coordination. But at the end of the day, the regions are very, very autonomous, very independent, and there is a lot of coordination among regions.
Okay,